Assalamu alaikum. Bismillahir Rahmanir Rahim. This is Dr. Ghufran Babar, and you are watching my YouTube channel. So today's topic is very interesting in terms of the child development, and it is on achieving bladder control or bedwetting. Usually, most of the children can achieve daytime bladder control by age 4 years and nighttime by age 5 years. This bladder control could be complete, like I said, or it could be like people can have continuous, intermittent, continuous leakage of urine, or sometimes there could be intermittent, and it could be primary nocturnal enuresis or primary loss of bladder control in which they have never achieved bladder control in the children. Versus secondary when they have achieved the bladder control for up to 6 months and then suddenly they lose that control, which is really very annoying for the parents, and they usually bring the kids to their physicians to get evaluated that what is the reason. So it is very common, up to 30% of 4-year-olds may not have bladder control. So parents have to understand that even normal kids may not achieve bladder control until late age. 15 to 20% of kids may not have bladder control up to 5 years. 10% of 6-year-olds may not have bladder control. And mostly it is the nighttime bedwetting, which is really annoying. And 3% of the 12-year-olds may have bedwetting, meaning they lose their bladder control overnight. And 15 to 20% of those with nighttime bedwetting also have daytime wetting or accidents. And the cause of bedwetting is really variable. A lot of time it could be genetics, that is, it runs in the family. People attain the sense of bladder control later in their lives, because remember, when the bladder is full, it stretches, it sends a sensation to the brain, and the brain, if it is well controlled through the signals, will decide whether the external urinary sphincter, which is under voluntary control, should be relaxed. If that sensation track, or the track of maturation reflex or the urination reflex is not developed, the child will continue to urinate mostly at night, or could be during the daytime too. Psychosocial, sometimes in certain stressful conditions, if the family is going through the stress, there's death in family member, there's a new arrival as a child, there could be separation of parents. So those are stressful events which will cause loss of control of bladder. Sometimes the situations in home are kind of different. There could be a wedding taking place, there could be vacation where people are not sleeping through the night, they stay up or they drink lots of fluids at odd times. So the child's physiologic pattern of life gets disturbed and they can lose the bladder control. Sometimes it has also been reported that some kids sleep very deeply. Their sleep is very deep, even though they want to wake up to go and urinate or pee, they cannot wake up. Certain sleep disorders like obstructive sleep apnea, when the oxygen saturation falls because of the obstruction of the upper airway, they can lose the bladder control. And usually there is a lack of diurnal rhythm of DDAVP, the hormone that controls the urine volume. So if it is not sufficient overnight, which will mean that the child will produce excessive amount of urination or excessive amount of urine and would pee too much overnight. And certain people may have smaller bladder size, so even though they may be wanting to hold, but because of the smaller bladder size they may have to go frequently. And when it happens frequently for younger kids, sometimes they may not be able to make to the bathroom, may urinate on their way to the bathroom. And then certain disorders like urinary tract infections, history of child abuse, the psychosocial stressor, and constipation is another factor which is present. Because if the constipation is present, it will a hard ball of stool in the rectum can push against the urinary bladder to cause excessive urination. Diabetes mellitus is another disorder which we diagnose when suddenly a child who was continent or had bladder control and starts having accidents and lack of control. So a detailed history is really, really, really very important when it comes to management. You have to ask the parents what's going on at home. You have to ask the child, or if the child is able to cooperate to figure out, and then you have to rule out the organic causes one by one. And a detailed physical exam will really help. If there is lack of, there could be vignette in which you could be told that the child has lost his gait, is stumbling, then there is a sign that there may be spinal disease which is affecting lack of bladder control because of paresis or paralysis of external urinary sphincter. Then you have to do imaging, MRI. You may have to do the bladder ultrasound to see if there is any problem in the bladder or the urinary tract and kidneys. All these things could be imaged. Urine could be tested, which will rule out infection. Diabetes mellitus, diabetes insipidus, in which you don't have sufficient amount of DDAVP or desmopressin, the hormone that controls the urine volume. So all those things, starting from history, a physical exam, and anal wink is another reflex that is indicated, in which if you stroke the area of anus, the external anal sphincter constricts because of a reflex, just like we have the detrusor muscle reflex for testes. That is similar to anal wink, where you stroke along the anal area and it constricts. So those are the physical exam things that you have to figure it out. And once you have made the diagnosis, you have gone through the list of causes which we discussed. Could be genetic, psychosocial, sleep problems, lack of DDAVP, circadian rhythm, or as such DDAVP, in which the people will urinate all the time, in diabetes insipidus, the bladder capacity, organic causes like UTI, diabetes mellitus, constipation, child abuse. So you have to do a detailed physical exam, making sure the child does not have unnecessary bruises, because sometimes when the child has bedwetting or is not attaining bladder control, the parents get upset and beat the children, and that further aggravates the problem, and the bladder control is not achieved. Going towards the management, you have to manage this as a family. So you have to educate the parents that like I discussed, up to 30% of 4-year-olds don't have bladder control, and the extreme is 3% of 12-year-old may not have bladder control. So you have to explain that this may be a normal physiologic thing, that the child has not developed the micturition reflex, in which your bladder distance sends a signal that the external urinary sphincter should be relaxed, and if you don't have that voluntary control, it will relax and the child may urinate, especially during the sleep. Other things which have been tried, alarm system. The easier thing would be not to let the child drink too many fluids after 7 p.m. Have the child urinate a couple of times before going to bed. And then alarm should be set up every 3 to 4 hours, in which the child could be wakened by the parent, or the child could wake him or herself and go and urinate, so that the bladder doesn't reach to its capacity where it will be overflow and overflow incontinence type of a thing. And support by the parents is very important. You should not blame the child. Just keep on reassuring the child that eventually you will attain the bladder control. Remember, it is really very thing of being a shame for the child. They feel ashamed, especially when the siblings and the parents laugh at them, or you have beat again in the bed. So that's why psychosocial support is very important. In terms of the pharmacotherapy, DDAVP or desmopressin is the hormone which acts at the kidneys and decreases the urinary output. So that is by increasing the absorption of urine from the kidney tubules. So this medication can be tried overnight. A lot of times when you stop the medication, kids can go back into that phase. So that's very critical, that you have to stop it in a timely manner. Tricyclic antidepressants like imipramine has been used, but again you have to be cautious, because it can cause cardiac arrhythmias if there is an overdose, and this will also cause a relapse. Once you stop the medicine, it relapses. So you have to be very tactful in weaning off the medication. Other things are the behavioral things, ask the child to try to hold the urine during the daytime for longer time if the child can, so that voluntary control is established. And other exercises could be done, like bladder stretching exercise if the bladder volume is low, scheduled timed voiding every 90 to 120 minutes during the daytime and nighttime, and treatment of coexisting constipation. Constipation is very common. In most developed world, their diet is low in fiber. So due to that, the refined sugars and all the carbs, proteins or fats that are consumed, they decrease the stretch in the large intestine, which basically causes the defecation reflex because of the stretch. So increasing fiber, giving 5 servings of fruits and veggies a day will be really useful. Hydration is very important, in adequate amount during the daytime and at night, to stop overhydrating. Lack of soda drinks or juice is important, because a lot of kids drink lots of juice, which can cause osmotic diuresis because of high sugar consumption. And the other thing is a lot of fluids after 7 p.m. should be discouraged. Hopefully, this discussion of bedwetting would have added to your knowledge. Please like and share this video, and please subscribe to this channel. Again, thank you. Best of luck.